All right, so he's been named Reese, by the way.
Reese.
One of our former students, yeah, the one that, because somebody used him on Friday. All right, so where do you want to start? Let's start on the upper right. So we're going to start with our molars. How do you know what to do for your vertical angles? I do have these little cheat sheets. These are in your manual as well. But there are some predetermined vertical angles that work, well for the majority of people. Are they perfect for everybody? No. You might have to alter them. And if you look in your textbook, like on here it says for the maxillary molar, to use a plus 20. In your textbook it'll say 20 to 25. So it is kind of a range. But I just kind of simplified it there. But that being said, let's say you took a picture on this guy and you did everything right and you looked at it, but the root apices, you couldn't see 2 to 3 millimeters around the root apices. How would you want to change your vertical angle? Would you want to increase it or decrease it to see more of your maxillary root apices? Increase. So then you'd, maybe increase by 5. If you did everything right and you couldn't see some of your occlusal plane, but you had a lot showing up in the root apex area, then you'd want to decrease. So you always go closer to what you want to see more of. So again, these are kind of, good for the general public, but you may have to change things, based on your results. And always set the vertical angle first before you put anything in the person's mouth, just to be nice to them because, it's uncomfortable. He's all full of black sediment. And just to review this, find the 0. Anything above it is positive, anything below it's negative. And so we're going to go up to our plus 20. So figure that out first so that you can be really quick. And then as far as putting this into the device, so this is a snap array. It's actually the newer version of a snap array. I think I brought the old one in here to compare. But the older one has teeth. This just has like little foamy things so that it doesn't damage the plates. This would be your posterior end. I should hold it here so you can see it. This is the anterior end. So this goes in like this and the patient bites. They don't have to hold it. The older style one, they actually had to hold it in place. So it's improved. It's nice because, you don't have to worry about the person moving. And when you use this side, the fatter side is for them to bite on. The thinner side goes on the lingual. So for my upper right, it would be like this. Okay? And then put the dot in the slot. So the dot always goes on the side with the slot. And then just leave yourself a couple millimeters. Make sure that you don't, you have to take into consideration the wrapper here. But just leave yourself a couple millimeters hanging out. Okay? So when this is in your patient's mouth, this is all you're going to see, right? So you're going to need to use this as a visual cue to tell you where your receptor starts. So we just assume it kind of starts here, even though it actually starts a little further back. But just to be safe, we assume it starts here and doesn't really go any further down than maybe a millimeter or 2 beyond this. So when I bring my PID to cover it, I know it needs to just clear this corner in order to cover it so I expose the whole thing. Okay, so that's your only visual cue. So now for placement, and well actually let's talk about patient positioning first. He is in the correct position for the maxillary arch. And if you look here, you can kind of see there's a little diagram. It tells you the allotragus line should be parallel to the floor. So, and I know it's a little challenging with these chairs, but he's not too bad. His is a little elevated, but that's as far as I can get it parallel, just based on his anatomy and the anatomy of the chair. So chin tucked down, allotragus line parallel to the floor for maxillary, and then chin up, and then you want a line that goes from the corner of their mouth to the tragus of the ear parallel to the floor. So basically it's whatever occlusal plane you're working on should be parallel to the floor. It's a good way to remember it. So we're working on maxillary. So I'm going to get far enough back to cover his last molar. I don't need to go any further anterior than the second premolar, right? I wouldn't expect to see anything more on my receptor. And then now, unlike paralleling, I'm going to place this really close to the teeth so it can be touching the linguals of the teeth. And have him bite down. So it's going to look like that. And now it's just a matter of figuring out where are those molars so that and where's that receptor so I cover it, right? Because I don't want a cone cut. But I can use anatomical landmarks to help me figure that out. And we all know that if you follow a line down from the outer canthus of the eye, what's right here? Your molars, right? So if I bring my PID over here to the outer canthus of the eye, that should be where my molars are. How do I try to make sure that I have open contacts? What did you do when you did your bite wings? Do you remember us talking about making sure that the face of the PID is parallel to their arch?
Yeah.
So we're going to do that as well, right? Because we don't want to have overlap. We want to try to have open contacts. And then I just need to make sure my PID is high enough that it's covering the area where the receptor is. So you have to kind of envision, okay, these are the occlusals and the roots go up here, so this is kind of the area that I should be covering.
Okay.
Okay? So let's get this over to that area. So if I take this red line and just bring it over here so that I'm back here by the outer canthus of the eye, I should be in the neighborhood of the molars. Okay, so I'm going to do that first. The second thing I'm going to do is just try to, pivot this so I keep the face of the PID parallel to his arch. So if I kind of maybe swivel it just a little bit like that, to me that looks relatively parallel, right? That's just going to help me with my contacts. But do I look too low still? Well, how do I know? I need to bring the PID up a little bit. How do I know how far to bring it up? Well, I know I don't want to bring it any higher than this bite block, right?
Right.
Because this is where my receptor starts. So if I raise this, and I'm going to take one of these so you can kind of see it a little bit clearer. If I raise this so that it is just at the bottom of this bite block, that should be really the perfect height, right? I don't want to go any higher than that because then what would happen? I'd cone cut, and I don't want to go any lower. There's no need for me to go any lower because I want to make sure I'm covering, the whole receptor.
Right.
So if I just raise it to that height, I should be good. Now let's just double check and make sure I don't have to tweak it. So what I like to do is once I've raised it to the right height, I just lay this flat against the PID and kind of roll it around and just make sure that it clears this corner of the bite holder, the bite block.
Mm.
Is it clearing the corner or is it grazing it right here?
It's grazing it.
Ever so slightly, right? Probably won't matter, but just to be safe, I'm going to move it just ever so slightly forward. I think that'd still be okay, because as you saw before, there's a couple millimeters of leeway there. But that would be my molar view. So really not that hard, right? You just have to think of a few steps. So let's do the premolar. So take that one out, goes on the tray upside down. Oh, don't throw it, goes on the tray upside down. To edit that out. And we'll leave a couple millimeters hanging out. Too bad I don't know how to. It's just going to be in there. Okay, so now we have to change our vertical angle. Still leaving them in the axillary position. We're not moving to the mandibular yet. So if you look over here, you can see it says right here for maxillary premolars plus 30. So again, here's your dial. We're already at 20, so we're just going to increase it to 30. It's a little bit steeper for our premolar area. So if you read, this actually gives you directions of what your anatomical landmarks are, but I'm just going to tell them to you. So premolar, it's up here by the pupil of the eye. So if we follow a line down from the pupil of the eye, that should be where your premolars are. So I'm going to do the same thing I did with my molar. I'm going to bring this red line over here by the pupil of the eye. But be careful not to do this. A lot of people just bring it right in front of the pupil. I still need to keep the face of this parallel to the teeth I'm imaging, parallel to his premolars. Okay? So let's put this in and we'll see what this is going to look like. So I can easily visually see that I have receptor behind my canine. That's very easy for me to see. When you separate the arches out, it's harder to see when you do bite wings, right? But with periapicals, it's very easy to see that your placement is far enough anterior. If you can see receptor behind the canine, then you should capture it. Okay, so now I'm just going to bring this red line up here by the pupil, but I'm also going to be mindful of keeping the face of the PID parallel to those premolars. Okay, but I'm still too low, so I'm going to raise it up so that I come to the bottom of the holder. And then I'm going to check and see if I clear this corner, and it just grazes it right here, right? Mm-hmm. So I'm going to move just ever so slightly anterior. That's your premolars. Okay, everyone's on board. All right, 2 for 2. Okay, now let's switch to the mandibular. So for the mandibular, I'm going to change his head position. So I'm bringing his chin up a little bit. You don't have to go too crazy with that, just enough that it's, again, the corner of the mouth to the tragus of the ear should be parallel to the floor. One nice thing about those new mannequins, they're easier to manipulate that way. And now, of course, all my measurements or all my vertical angles are going to be negative. So positive for the maxillary, negative for the mandibular. And it's only going to be a -5, so it's really not much of an angle at all for those molars. So I'll start with that first. again, I want him to bite on this wider part here. Skinnier part goes on the lingual. I want to have my dot in the slot. So this time the dot's going to be up, right guys? So that's okay. It's dot in the slot, always on the side of the slot. We're going to go between the teeth and tongue, so never put it on the tongue because that's going to cause your patient to gag. Far enough back. And then if we can get the distal, the second premolar, great. If not, since he has thirds, it's okay. But his teeth are so small, I actually can get everything. The third molar and the distal, the second premolar. So again, what's my anatomical landmark for my molars?
Outer canthus of the eye.
Yep, so I'm going to just bring this over so it's down here by the outer canthus of the eye. I'm going to keep the face of the PID parallel to his molars. And then I like to I usually try to get the bottom of the PID kind of level at the bottom of their chin. That means I know I'm covering, this area where the roots would be. All right, so I'm down by the outer canthus. I'm kind of level at the bottom of his chin and parallel to his molars. And now I'm just going to check and make sure everything looks good. So I know it's kind of hard because his lip is in the way. I'll just move it so you can kind of see. So am I above where the bite block starts?
Yes.
Yep. But then as I come around this corner, what's going to happen right here?
And cone cut.
I might cone cut. Now I can fix this one of two ways. I could lift it a little bit, because this is a circle. So if I lift it a little bit, that might help. And I can easily do that. I don't need to worry about, obviously the receptor doesn't go all the way to the bottom of his chin, right?
Mm-hmm.
So if I lift a little bit, it will probably fix my whole problem. Okay, so sometimes you can, instead of moving it anterior to fix it, on the mandibular just lift it a little bit. Just make sure you don't go too high, because if I were to go way up here, now I might cone cut, right? Because my receptor maybe is this low.
Mm-hmm.
But if it's, if I'm lifting it just a little bit and stealing a little bit of real estate from down here, that's okay. Because I didn't want to come any further anterior, because to me that looked pretty good. Because if I started to sneak too far this way, then I might cone cut back here. Mm-hmm. All right, so that would be what your molar image will look like. And then we'll do the premolar. So now we're gonna, obviously I'd get a new one, put that one back. Now I just need to make sure I can see my canine behind my receptor when he closes, so I might have to angle it a tiny bit diagonally across the front of his mouth. And my vertical angle is going to increase to -15. So now, again, I'm using the same anatomical landmark, the pupil of the eye. So if I bring this, so it's down from the pupil of the eye, but still keeping the face of the PID parallel to those premolars. So I have open contacts. The bottom of this level with the bottom of his chin. It would look something like that. And again, I'm going to check. So I'm definitely high enough, and then right here I'm just barely, I think that's going to be fine. It's just barely grazing it. Again, if I wanted to, I could just lift it up ever so slightly, and that would help me to clear that corner. So that'd be your premolar shot. Okay, so those are the posteriors. Now let's look at the anteriors. So with the anteriors, it is challenging with these number 2s, especially on this guy because he's got a really small face. So to put this in the holder here, if I should move this, it's just like a really just little gripper, rubber stopper almost. So you just pull back on this with your thumb and drop this in. So it's not going to be a real firm fit or anything. And then the dot is on the slot side, and we're shooting to the blank side. And then the person's going to bite on it. Now, unlike paralleling where we had them bite really far forward, now we want this receptor really close to the linguals of the teeth. And there are little grooves on the bottom of this that kind of help it nest on the occlusals of the opposing arch so it doesn't slip. But again, it's going to be pretty hard to place in this guy because his mouth is really tiny. So we'll see how this goes with this number 2. It's going to be a little creative. I'm going to have him bite pretty gently, but I think that'll be okay. So I'm going to capture both those teeth with one receptor. I got it as close as I really could without it sliding out. And now, instead of using, so they do have preset vertical angles that you could use. They're in your textbook. Like the preset for the canine would be 45, plus 45. But with this new holder where the patient bites on it versus holding it, those presets are a little too much. And so you'll get a nice picture of the root apices, but you won't see your incisal edges. It tends to chop off the incisal edges. So I have an easier way of doing it. Actually, I probably should have explained it before I put it in his mouth, but I'll do it with it in his mouth and I'll take it out and show you. What I'm going to do is tilt this or slant it so that it's at the same incline as this bite block. See how the bite block kind of travels up?
Yeah.
So I'm kind of making a V at the bottom of this and this extension of the holder. By slanting this at the same tilt or slant as my ramp, as my bite block. Can you see that?
Yeah.
Okay. So that's how you're going to figure out your vertical angle. So it's nice and easy, and I like doing it this way because if you go into an office and they, this is what they have, and you got to take X-rays, you don't have to be like, oh my gosh, I forgot. What are those readings for the anteriors? You can just visually assess it and figure it out yourself. So now I've figured that out. Now it's a matter of aiming. And we have two different options. With the canine, we can aim at the distal of the canine to try to open up that contact between the canine and the first premolar. Remember how we had so much overlap with paralleling? And I am going to have you do that when we do 3A. So when we separate out the canine, I'm going to have you purposely aim at the distal of the canine. I'll show you that in just a minute. But with the number 2 receptors, I'm going to have you still just aim between the canine and lateral. Okay? So I'm going to show you that. So basically, here's my canine and lateral. I just have to make sure I'm kind of aiming between them. And you can use this little red line here to kind of determine where you're aiming. And then once I figure out my aim, this is going to drift like crazy here. There we go. So once I figure out my aim, then I just need to bring this down ever so slightly towards the handle so that the bottom of the PID is below the receptor. Because if I leave it up, I might cone cut that very bottom edge of the receptor.
Okay.
So basically bringing it down slightly, towards the handle where it's below this ramp. I guess that's another way of looking at it. And then just make sure that it looks like you're, covering the circumference, the receptors within the circumference of your PID.